So we're continuing on our whistle-stop tour around the world, from Europe to Brazil to Malaysia. So next it's Dr. Hany Ariffin, I hope I said that correctly, who's going to talk to us about whether we should change Chompret criteria in populations like in Malaysia. Thank you.
Firstly, I'd like to thank the organizers for inviting me, and I must say that yesterday's opening ceremony and the glimpse of into the lives of the patients who are survivors of Li-Fraumeni and the families who deal with the effects of Li-Fraumeni syndrome clearly has made it worth my while traveling 30 hours to get here. So thank you. So today I'll be talking about the modified Chompret criteria and whether it should be further modified for Asians. Now, I am a pediatric oncologist working in the University of Malaya, and it is the second largest pediatric cancer center in Malaysia. So one of the things that how do you work this? Oh, right. One of the things that I'm often asked when I tell the diagnosis to parents is that they will firstly ask why. In our part of the world, there's always a lot of stigma associated with childhood cancer, in the sense that there is a sort of blame culture where the father or the mother will each blame each other for having the so-called bad genes. But as it turns out, inherited cancers are not common. And from this work that was published late last year by the St. Jude team, we see that actually germline mutations in childhood cancer are very rare, less than 10%. And if there is no family history or nothing to suggest an inherited predisposition to cancer, we would think that after that particular case, there won't be any further members that would be affected. But this is not quite the same with Li-Fraumeni syndrome. And therein lies a lot of problems, because what happens is that a person can have several cancers, like in this case, or they have several siblings who are affected. And because of that, we have situations where patients actually have marital discord because of it. And I think that is one of the reasons why, despite Asia being such contributing to a large percentage of the human population on this planet, for example, China, there are more than 1 billion people, yet the numbers of cases that you get from this part of the world is very, very low. It's because people don't want to know. People don't want to be labeled as a person who is carrying a bad gene, and hence reducing the chances of marriage and further stigma to the family. So to identify possible kindreds with p53 mutations, I'm sure all of you know that the Chompret criteria was devised and underwent several modifications, tweaking, to try and identify who are those who actually have a p53 mutation. And because it's so heterogeneous, it was very difficult to just pinpoint one cancer, so a variety of cancers were all grouped together and trying to make a sort of algorithm to try and see what are the best odds of identifying somebody with a p53 mutation. Now, this is the criteria, and basically why should we want to find out if somebody has a p53 mutation? And that is a question, again, that some parents ask me because I see the proband because I don't run a genetic clinic. I see them as a pediatric oncologist. And so when we see a child with a particular cancer, with a suggestive family history, or, for example, a child with very early rhabdomyosarcoma, age 3, for example, so we suggest this to them, and then they will ask why. Why do I need to do that? Because in Malaysia, for example, the moment that you discover that the person has a congenital condition, then the insurance will not pay. Most of the care is paid for by government. This is similar to, say, the British system, because we were previously under the British, and so we inherited their health system. But a lot of patients also take on additional insurance. And funnily, in our country, the moment that it's a congenital disorder, be it a hemoglobinopathy or an enzyme defect or whatever, or even a congenital condition like this is considered a congenital issue, even though it is, to me, slightly acquired after, because the way that it manifests is not 100% sure. So because of that, they lose out on their insurance, and so that's why it is better not to know. So when they fill up the insurance claims, there is a question there: is this condition congenital? And the answer that they prefer to say is no. And that's why we have barriers in trying to detect people who have inherited P53 mutations in our country. But notwithstanding all that, I think it's important because there is some benefit in screening, and this is the famous paper that all of us have been listening about, and this is from the Malkin Group in Toronto, that advocates that patients who have P53 mutations should have a screening strategy. And that's the strategy which has been designed following based on age of the patient, as well as what to do every year for the rest of the patient's life. Now, it's a very, very expensive strategy, and perhaps very difficult for people for people living in countries with limited resources to practice. Just to put things into perspective, in Malaysia, which is a country with a fairly decent economic growth, the GDP per capita is about 11,000 US dollars a year. Now compare that to, say, Great Britain, where the GDP per capita is about 46,000 USD. So you can see where there's a huge valley of resources, and therefore to advocate somebody to have an MRI may not be so, notwithstanding its benefits, but it may not be something that is implementable in Southeast Asia. Of course, the authors put up very strong evidence advocating its benefits. And of course, you have also heard from Professor Evans about the use of this modified screening protocol in Manchester. So this then begs two questions. One is, can guidelines used in North America or Western Europe be applied to East Asia? And when I mean East Asia, I mean Southeast Asia and Korea, Japan. But I do not include South Asia like India, the Middle East. And secondly, are the clinical phenotypes of LFS similar in that are seen in North America and Western Europe? Are they the same in East Asia? I mean, one of the first things that one would consider is that there is this huge variation in the genetic makeup. And one would think that the populations in Western Europe and North America are mainly of Caucasian stock, while that of Asians are completely different. Right. So we decided to try and answer this question by using data obtained from the IRC database. So, as I said, we did not include the Arab and Indian subcontinent, but this is a moot point because in the database there were no Arab nor cases coming from the South Indian continent. So we had 155 subjects from 41 families from all over East Asia, and 138 of them had cancer. And we compared the parameters with 440 subjects from America and 352 subjects who were from Western Europe. First thing we noted was there was not much difference in the mutation hotspots, and you can see that the majority of them were in the DNA binding domain between codons 100 and 300. And when we looked at cancer accrual, you can see that it is roughly the same. Can point this? Okay, the same. This is quite remarkable. It's exactly the same rate of accrual until the age of about 35. That's when we notice a difference emerging between the ages of 35 and about 50, 55. And so we were wondering what can explain this, because there suddenly seems to be this blip that happens there. So we first looked at the incidence of the LFS spectrum tumors in the Asians compared to the North Americans, and this included the pediatric adrenal carcinoma and all the young adult onset of sarcomas and breast cancer. And we found that there was no significant difference, so it was about the same. So what about the tumors? I mean, logically, it means that whatever has counted for the increased rate in cancer accrual must belong to cancers that are outside of the narrow LFS spectrum. So we looked at the same suspects again, adrenal carcinoma, but this time in the adolescent group, adolescent and adults, or the late onset sarcomas, breast cancer, and brain tumor. And again, you can see that there was no significant difference. But what about the tumors that are definitely not mentioned in Chompret criteria? And these include things like colorectal cancer, the cancer of the gonads, reproductive system, GI tract cancers, etc. And what is obvious here is that stomach cancer stands out quite remarkably amongst the Asians. Gastric or stomach cancer presents at, what we found was that gastric or stomach cancer presents at an age which is much younger in the Asians. It's not that it doesn't happen in the Caucasian patients with Li-Fraumeni syndrome, but it does. But the difference is that the age at presentation was much younger, at 39 years, as compared to the median age of 46 in Caucasians. The other thing we noted was in Asians with gastric cancer, more than half of them presented before the age of 40, 56%, and 15% occurring even before the age of 30. And also, what was notable was that the individuals with Li-Fraumeni syndrome who developed gastric cancer lacked a family history of gastric cancer because, as you know, in Asia, gastric cancer is the incidence is higher than other parts of the world, and there may be some predisposition in certain families who have gastric cancer. So one may argue that given the fact that gastric cancer is more common in the Far East, so of course it is not unexpected that one of the cancers that a person with a P53 mutation would develop would be a cancer that is prevalent in their community. And that is not entirely untrue, because it is quite possible that whatever triggers that have caused gastric cancer in the population, be it diet or infection with H. pylori, may also affect the P53 carrier. But when you actually do the math, if you look at, if you standardize this based on what is the incidence of another cancer, for example, taking colorectal cancer, comparing the incidence rates of, say, colorectal cancer between Asians and the Caucasians, and then you try and standardize that, it still comes out that stomach cancer is twice more common than the estimated, what you would expect based on the prevalence in the population. So this cannot be explained by just the presence or the increased prevalence in the population, but it must be possibly the effect of a combination of the two. So there are several hypotheses that can explain this, and they are not mutually exclusive. These include a combination of, say, a chronic H. pylori infection or a very high salt diet in Asia. we eat a lot of products that are cured with salt. There's salted fish, salted prawns, salted vegetables, etc., with nearly every meal. And on top of that, I think there may also be the influence of certain polymorphisms that are seen in the susceptibility genes that have been implicated in the development of GI cancers, and these include genes like XRCC1 and PPAR, where we have seen differences in, say, the Han Chinese compared to when you compare to the 1000 Genome Project, where the majority of the patients that make up this database are Caucasian. So could it be a combination of these things, and that has led to the increased incidence of stomach cancer in people who have P53 mutation carriage? So to answer that question again, are clinical phenotypes of Li-Fraumeni syndrome similar in North America, similar in the North American and Western Europe as in East Asia? The answer is it's probably similar, but not exactly the same. And therefore, if they are not the same, and for the purpose of screening, notwithstanding the cost, can the guidelines used in North America or Western Europe also be applied wholesale to East Asia? And my answer is maybe. With all things being equal, if let's say tomorrow the GDP of Malaysia were to triple and MRI was not a problem, then yes, perhaps we would adopt the Toronto Protocol. But we may also consider doing gastroscopy for patients who have LFS, LFS individuals. But whether that is a cost-effective way or not is another remains to be studied. But clearly, stomach cancer or complaints related to the stomach or GI complaints should not be taken lightly in patients who have Li-Fraumeni syndrome. So with that, I thank you, and I am happy to take any questions.
Thank you very much. I think we published a family a few years ago with 2 stomach cancers, age 35, but with a 175 mutation. So I think we believed a little while ago that it might be part of the spectrum, but obviously with a higher incidence in Asia, it might be something that is more readily evident, because stomach cancer incidence in Western Europe has plummeted over the last 70, 80 years. So it's becoming a much less prevalent cancer in the West, and that maybe is why we haven't been seeing it in our families. Any questions?
Very nice talk, and thanks for bringing awareness to all the other issues with genetic testing that come with it. So just a couple points and to highlight a few things. I think these criteria initially, Li-Fraumeni and Chompret, were the way forward. I think now as we are getting into doing more sequencing, albeit in some places the resources aren't where they should be to do it, we need to be thinking about molecular classification just in general terms for predisposition. Because as all of us who take care of patients, we see exceptions to every rule. And I think as people do identify themselves with a single mutation sometimes, there's a lot more to what's going on. And I think some of these hurdles in terms of stigma that go with genetic testing, as people are educated that we're all mutants of some sort, 30% of the adult population is going to get cancer. It's really going to be figuring out the constellation of molecular aberrations. So kind of in terms of reclassifying new criteria for X, Y, and Z, I just think that thinking about things on a molecular level is important. Thanks.
I take your point. I suppose where we are at, it would be much easier to use clinical parameters to try and decide who would then be selected to have this P53 mutation screening.
I think, just in terms of, and this is kind of a societal point to be made, but I think in terms of the resources that go into pediatric cancer in general terms, there are tremendous resources. And the clinical picture is important. It's a means to kind of raise red flags and for us to be aware more quickly, I would say. But the genomics has brought us to a point where multidisciplinary medicine is really taking on a new definition. And these international consortiums are very, very important, because I think that there are a lot of sequencers out there just sitting there, and the concerted efforts together to use them, I think is a worthy effort. But I guess the point I'm trying to make is, I think there are resources there if people put their heads together, and I think a lot of the taboo that goes with genetic testing will get broken down more quickly with those kind of efforts internationally.
Thank you.
Thierry?
Yes, thank you very much for this excellent talk. I completely agree with your conclusion. So I check on our last series that we published in Journal of Clinical Oncology on more than 250 families corresponding to more than 350 carriers. When we updated the data, we had no evidence in France for an enrichment in gastric carcinoma. Nevertheless, I fully agree that in specific population exposed to specific diets, to a specific carcinogen, P53 mutation acting as permissive mutation, you will increase the risk of this type of cancer. So we have to consider that, and probably we are going to see more and more gastric cancer in older patients in specific populations. So I fully agree with your presentation. Thank you.
Excellent talk. I wonder if, to help tease apart the gene-environment interaction, if you've looked at incidence of gastric cancer in Asian populations outside of Asia, for example, in Europe or North America with Li-Fraumeni as carriers.
One of the limitations of our study was that there is a big assumption that patients who in the database, those who come from North America or Western Europe is Caucasian, but of course it could be an Asian who's living there. That's entirely possible. Yes, so I completely agree. But I think one of the things that we may have to consider is that, for example, the polymorphism that I mentioned, seen in the Han Chinese in XRCC1. So if that is one of the reasons that has contributed to the reason why P53 mutation carriage has led to stomach cancer, then irrespective of whether that person lives and eats, say, a Western diet, it might still be at risk. Yeah.
Thanks very much,
Thank
Hany.
you. Welcome.